Welcome to AETCM, the Emergency Medicine channel. Today, I'll be presenting a case of a 58-year-old female patient who presented to our ER with complaints of dysuria, abdominal pain, lethargy, generalized weakness since 3 days. On initial 10-second assessment, patient is conscious and oriented, talking in full sentences. Airway was patent, there was no pooling of secretions. Breathing was air and trace bilaterally equal, respiratory rate of 20 breaths per minute and saturation of 97% on room air. Circulation wise, BP was 150 over 60 millimeters of mercury and heart rate was 107 per minute. Disability wise, GCS was E4, V5, M6 and pupils were equal and reacting to light. Exposure wise, temperature was 98.5 degree Fahrenheit. Adjuncts we had taken a ECG which showed a sinus tachycardia with a right bundle branch block pattern. Bundle branch block was seen with QRS of 132. And coming to the secondary survey, we had a 58-year-old female patient who had a complaints of burning micturition since last 3 days, and it was associated with increased frequency of micturition. She also complained of abdominal pain, which was gradual in onset and progressively increased and mostly involved the bilateral flank regions, and it was intermittently present. And severity was almost moderate intensity, and then she also had complaints of generalized tiredness, generalized weakness, and also complaints of body ache, generalized body pain. And she also gives history of palpitations on exertions since last few months. Last few months, which was associated with sweating episodes on minimal exertion.
Most common cause? Female patient, palpitation, sweating episodes.
It can be anemia.
Most common is anemia. Hyperthyroidism should be kept in mind. Okay, then
coming to negative history, there was no history of fever, hematuria, reddish urine output or vomiting. There was no history of recent catheterization, no history of weight loss, irritability, any altered sensorium, sweating, tremors, diarrhea, no history of cough, breathlessness, chest pain, syncope. Her past history, she is a known case of CA sigmoid, moderately differentiated, post-sigmoid colectomy 2 years back, and post-chemotherapy 1 year back. And also she had a recent surgery for colonic polyposis, post-polypectomy done 2 weeks back. And also during that admission, she was diagnosed with newly detected hyperthyroidism. Okay. And she was started on neomercazole 10 mg BD. And also she is known case of hypertension and on Amlong 10 mg OD. And coming to allergic history, there is no known any past history of allergies. And coming to examination wise, patient was conscious, oriented, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edemas. Abdomen wise, it was soft, very minimal tenderness was present on the left flank. Bowel sounds were present, and chest wise there was air and trace bilaterally equal. CVS wise S1 S2 was normal. CNS wise GCS was E4 V5 M6. Pupils equal and reacting to light, and patient was moving all 4 limbs. On examining for tremors, there was an intentional tremor present. And
what is intentional tremor?
When patient just stretches out her arm, there is mild tremors present. So usually intention tremors are present if there is any like cerebellar lesions or any hyperthyroidism, any sympathomimetic overactivities, there can be tremors. Then we had further evaluated the patient, and the labs we had sent which showed total counts of 11,900, CRP of 36, and creatinine of 0.61. URE was done which showed numerous pus cells and 30 to 45 RBCs. And incidentally, we had also seen calcium levels to be on the higher side. It was around 12.74. And phosphate levels were around 2.1, mildly on the lower side. And PTH levels was sent as part of workup, and it showed as 147. And also,
what is the normal PTH level?
Normal PTH less than 60s, 50s. Okay. And we had sent further workups also. Vitamin D was sent, which was 19.6 on lower side, and urinary calcium and urinary creat was sent, and urinary calcium was 9.48 and urinary creat of 18.8, and ratio was calculated to see for the calcium excretion, and it was around 0.5 on the higher side. Cutoff is 0.2. So if less than 0.01 is reduced calcium excretion in the urine, and if it is more than 0.2, we can take it as higher excessive calcium excretion.
So there is a hypercalcemia in this patient.
Hypercalcemia with the hypercalciuria. And PTH is elevated.
Is secondary to hypercalcemia.
Calcemia.
Right. Okay. So what are the type of hypercalcemia? What are the causes of hypercalcemia?
Cause of hypercalcemia, we can say based on if it can be either due to parathyroid related causes, which can be primary hyperparathyroidism, or it can be something called as a familial cause, which can be a familial hypocalciuric hypercalcemia, in which the urine calcium levels will be reduced. And then there can be due to drug induced, like lithium. Lithium carbonate can cause parathyroid stimulation and cause raised PTH levels and cause hypercalcemia. That is one side, and the other side non-parathyroid causes are there, in which one is malignancy related. So in malignancy related, we have bone malignancies as well as bone metastatic lesions. Metastatic lesions will have lytic lesions, so they'll have hypercalcemia. And in bone malignancies, there can be leukemia, lymphomas, multiple myeloma can be present, and if there can also be secondary to paraneoplastic syndromes. So in cancers or in carcinoma of the breast, lung, CA breast, and also in renal carcinoma also, it can cause hypercalcemia by parathyroid hormone related protein mechanism. And then further we have the vitamin D related causes, like excessive vitamin D intake, vitamin D intoxications, or due to a condition like granulomatous diseases, chronic granulomatous diseases. Secondary to that, there can be increased production of the vitamin D because of the mononuclear cells excess. There can be excess production of vitamin D. So that is for the vitamin D related causes for hypercalcemia. And also there are other causes like increased bone turnover. So in increased bone turnover, it can be due to hyperthyroidism itself, or it can be due to immobilizations, or due to drug induced like thiazide diuretics. There can be increased bone turnover. Then the last one is due to renal failures. So they can cause tertiary hyperparathyroidism. So in tertiary hyperparathyroidism, usually the phosphate levels will be raised, and the alkaline phosphate levels will be raised. But in primary hyperparathyroidism, the alkaline phosphate levels will be raised, and also the phosphate levels as such will be lower side. Whereas in renal failure, it will be higher side.
Okay.
That's how we can differentiate in renal failure, and that is the main causes. Then
in hypercalcemia, what are the main symptomatology patient will present as?
The patient can have we have mnemonic like we have the bones, stones, abdominal groans, or psychic moans.
Yeah.
So stones are like there will be renal involvement, so they can be polyuria or nephrolithiasis, renal stones can be present, or renal failures patient can present with.
Okay.
And in bones there can be bony pains like fractures can be present, osteopenias can be present with increased reabsorptions. And then abdominal groans, mostly patient will have abdominal pain, vomiting episodes, or can have constipation, jaundice can also present.
Okay.
And in psychic moans, patient will have delirium, like psychosis, confusion, irritability, stupor, comas can be present.
So what are these are the clinical symptomatology that patient can present. What are the signs that you look for? What are the investigations wise? Investigation already you are covered in the initial itself. ECG finding.
ECG finding, we can in hypercalcemia, what we see is a short QT interval and widened T will be present. So
short QT
is the main
ST.
ST segment. And also
what is more prominent? What is there any propensity for arrhythmias present?
Yes, ventricular irritability will be present due to hypercalcemia and can lead to ventricular fibrillation and cardiac arrest.
Correct. So ventricular irritability is one of the things that can be seen in hypercalcemia. Okay. Symptomatology, investigation. Obviously, we have to send the
PTS levels. So based on the PTS levels, if it is raised, it can be due to hyperparathyroidism, due to parathyroid adenomas,
Primary
parathyroid
or
carcinomas,
Primary or secondary?
primary and parathyroid carcinomas, adenomas, and due to drug-induced, as we said, lithium. If the PTH levels are high, then we can differentiate it based on, as we said, the urinary calcium excretion. So ideally, we have to do a 24-hour calcium level excretion level, but we did a spot one with urine calcium by urine creatinine. So if it is on the higher side, it is more likely the primary hyperparathyroidism. But if it is on the lower side, it can be a familial cause like familial hypocalciuric hypercalcemia, hyperparathyroidism. And if the PTH levels are normal, then we'll go to the other side of evaluation where we have to send the PTH-RP, which is the parathyroid hormone-related protein. So these are released by as part of the paraneoplastic syndromes. So they have similar action as the parathyroid hormone. So if it is raised, it can be due to malignancy causes. If it is not raised, then we have to further evaluate with vitamin D levels. So if vitamin D levels, we have the 1-hydroxy and 1,25-hydroxy, 25-hydroxy and 1,25-hydroxy vitamin D, which is calcitriol. So when you send the calcitriol levels, if it is raised, it can be due to causes like granulomatous conditions like sarcoidosis, lymphomas and all can lead to release of or the formation of calcitriol directly. So that will raise the calcitriol levels. If it is in case the 25-hydroxy vitamin D is elevated, then we have to suspect vitamin D intoxication, excessive supplementation and all we have to suspect. If though all of these are normal and PTH-RP and vitamin D levels are normal, we have to suspect other causes like metastatic bony lesions or any immobilizations. Other causes we have to rule out. Multiple myeloma workup has to be done.
Okay.
That is how we work up the patient.
How do you proceed with the hypercalcemic patients treatment?
Treatment we have basically we grade based on the levels into mild, moderate, severe. Mild is less than 12 milligram per deciliter. Then we have 12 to 14, which is moderate. More than 14 is severe. So less than 12, mild, usually patients will be asymptomatic or mildly symptomatic, like minimal lethargy only they will be presenting with. Okay. So in those patients, we just need to avoid any trigger factors, like what can again worsen hypercalcemia, like patient should be dehydration should be avoided. So volume depletion conditions, like we should avoid volume depletion by hydrating the patient, either as oral fluids or IV fluids. And then we have to avoid drugs which can cause hypercalcemia, like thiazide diuretics or lithium carbonate. Drugs you have to avoid. And then excessive supplementation has to be avoided, like calcium supplementation, vitamin D supplementation has to be avoided. Then even in moderate hypercalcemia also, if it is from 12 to 14, if the patient is asymptomatic or mildly symptomatic, the same treatment will be undergone. Just hydration will be required.
What is the extra step? What is the severe hypercalcemia?
If severe hypercalcemia occurs with our patient is severely symptomatic, and then we have to start the patient on IV fluids at a higher rate. So we have to start around 200 to 300 ml per hour. Around we have to give 10 liters per day. And we have to get a urine output around 100 to 150 ml per hour. But the challenge will be there if a patient has a renal failure or cardiac failure. So in those patients, we'll have to also add on to with Lasix. So Lasix, we can give around 80 mg, higher doses of Lasix, 80 to 100 mg every 1 to 2 hourly we can give bolus dose, or we can start on infusion. Okay. And maintain the urine output. Okay. And after that, if the patient is still refractory, we can add on therapies like bisphosphonates can be given. So bisphosphonates mainly the action is based on the osteoclastic inhibition. So when the osteoclast is inhibited, the bone resorption is reduced. So that will cause reduction, will worsen the hypercalcemia.
What about a patient with hypercalcemia presenting to ER in an altered behavior? Like patient was found to have a decreasing sensorium, not just sensorium, decreasing memories and weird behavior for past 4 to 5 days, and on evaluation you found to have a calcium level of 16. Okay, adequately hydrated patient. What do you do? But there is renal failure. One of the complication of hypercalcemia is renal failure. So renal creatinine is 3. What do you do then?
So then we can proceed directly to dialysis. If it is above 16 and severely symptomatic, we can directly go for dialysis.
Okay. So severe hypercalcemia is the indication for dialysis. Right. And what are the other indications?
High dose of calcium intake.
High dose of calcium, like higher serum calcium levels, right?
Above 16 levels we have to do.
What
Or a patient is in renal failure, we can't give any more fluids.
Yes, renal or other organ
cardiac
compromise.
failures.
Yes, organ compromises conditions, renal or cardiac organ compromise conditions we have to give. We have to initiate on dialysis.
Or arrhythmias, seizures.
Arrhythmias or any neurological complications. So these three conditions we can directly proceed with dialysis rather than starting on fluids and forced diuresis, right? In other patients, mildly symptomatic patients or moderate symptomatic patients without neurological or arrhythmias, as you told, fluids, forced diuresis and bismuth can be given. Fine. So that was hypercalcemia management. So this patient, we sent serum PTH level. That was elevated.
Elevated 147.
Nearly twice the normal value. So what we think, it is secondary hyperparathyroidism.
Primary hyperparathyroidism. So phosphate levels are on lower side.
So did we get any ultrasound?
Ultrasound of neck was done, but obvious masses were not found.
Okay.
So a parathyroid gland as such was visualized as normal.
Normal in size.
Further plan was only being made after the patient's present condition settles.
Okay. Now this patient also had hyperthyroidism.
Yes, TSH was less than TSH was less than 0.05 and free T4 of 1.4, which is on normal side, like a higher upper limit of normal, and free T3 of 5.63, which was raised. And patient was on neomarcosol 10 mg BD.
Okay, she was already started on neomarcosol. This patient is now presenting to you with urinary tract infection. What is the thyroid complication you are expecting the patient to develop?
Thyroid stoma infection with...
Yes, there is an infection. There is a stress factor right now. So there is a high probability this patient can go to thyroid stoma. Well, how will you identify thyroid stoma in a patient?
So thyroid stoma patients can present with features like the temperature, like the patient have fever, hyperthermia. Then there can be any CNS effects, like patient can be agitated, delirious, or present with seizures, comas, then stupor or coma, and then serious effects like tachycardia, atrial fibrillation, or cardiac failures. Cardiac failure can be present.
What type of cardiac failure will you be seeing in hyperthyroidism?
High output cardiac failure.
High output. It's a preserved ejection fraction. High output cardiac failure. Main reason for cardiac failure will be hypertension. Hypertension. Blood pressures will be higher. So patient will have tachycardia, hypertension, arrhythmia, most commonly atrial fibrillation. Then you will have hypertension and high output cardiac failure. These are the complications. Okay. And hyperthermia. Okay. So this patient's temperature was pretty normal, right?
Temperature was 98.5.
98.5. So hyperthermia is not
mild
there.
Tachycardia.
Here we are not suspecting thyroid stoma as such. But if you suspect thyroid stoma, how will you prove? Is thyroid stoma an investigative diagnosis or a clinical diagnosis? It's a purely clinical diagnosis. It has nothing to do with your T4, TSH levels. So if a patient is already hyperthyroidism and on medication, doesn't mean that patient will not develop thyroid stoma. Correct. So this patient you admitted, you are finding this patient to have persistent fever. Like you are admitting for UTI, already there was some mild fever, but this is persisting or it's not resolving to paracetamol, and there is persistent tachycardia. You suspect thyroid stoma. How will you proceed with the management?
So to confirm thyroid stoma, we have certain scoring systems, like we have Birch-Wartowski scoring system. So based on the temperature, we have grading 0, 5, 10, 25, like that the grading will be there.
Okay.
And temperature, we have GI effects based on nausea, vomiting, abdominal pain, or jaundice. Jaundice will be severe. And if there is any involvement of CNS like delirium, or a patient has seizure, coma, then based on that
severity scoring has to be done.
And if it is more than 45, we have to take it as thyroid stoma. 25 to 45, around it will be an impending thyroid stoma. Less than 25, we can rule out a thyroid stoma.
Hyperthyroidism. Okay.
And then when patient comes here, we have to initially settle the temperature. So you have to give cooling blankets.
Correct.
You have to give cooled IV fluids. And
peripheral and central cooling
has to be
procedures has to be given. Cold saline infusions, cold saline gastric insufflations,
can be given,
and as you told,
bladder lavage can be given.
Correct. All these things can be given. What else?
Then after cooling the patient, if there is infection, patient is in sepsis tissue, we have to start on antibiotics. And then
Correct
after
the
that,
source of
the main
stress.
reason for this thyroid storm is the beta adrenergic overactivity.
Correct.
So you have to stop that by giving beta blockers.
Correct.
So most
that is the
preferred
most important one, right? Early use of beta blocker is very much important for the symptomatic management of the patient, because this patient will worsen due to serious effects, isn't it? That is the one thing that can kill the patient very fast. So early beta blocker is very important. What will you give?
What we have, which has a CNS penetration, is propranolol.
Okay.
Whereas other are it's an oral agent which is available here.
Correct.
So we can give a dose of around 20 to 40 mg. We can start as a 6 hourly dosing. We can start and then taper down. Or if you have a sustained release preparation, we can start on higher doses. BD dosing we can give 80, 120.
What is the complication regarding that, or what is the disadvantage of giving propranolol in ER?
Propranolol issue is that if a patient has a CNS symptom, then we won't be able to give orally. We have to then insert Ryle's tube and give a rest for aspiration.
Won't be able to take tablet form, but we are giving propranolol for CNS penetration, right?
CNS penetration.
Yeah. What else? What is a disadvantage in ER? Like propranolol is the drug of choice. There is no doubt propranolol is the drug of choice, but in ER, the things are much more acute control, right? So, what will be a better drug for symptomatic management of hyperthyroidism in ER, for ER?
Calcium channel blockers, diltiazem.
IV beta blockers. What is the IV beta blocker will you give?
Metoprolol.
Metoprolol or esmolol?
Esmolol.
You have esmolol. Yes. Esmolol will have tachycardia control, hypertension control, isn't it? So you want these two control as much as early rather than anything else. So obviously CNS symptoms are important. I'm not saying no, but tachycardia and arrhythmia prevention is very much important here. So IV, initial dose of a esmolol IV followed by a propranolol 6 hourly will maintain the patient's vitals, and then you can taper propranolol according to the symptoms. Okay, so that is beta blocker. What else will you start?
Then if the patient is having any bronchial asthma history and all, then we can even try calcium channel blockers, and like diltiazem or verapamil. IV diltiazem is available.
Okay.
So we can give that, or then after that, if the patient we have to give after controlling the beta adrenergic symptoms. And also in cardiac failure, like if the patient is having up to moderate cardiac failure and all, we can give these drugs. But if the patient is having severe cardiac failure, maybe we can add on with a digoxin can be given.
Correct.
So if atrial fibrillation with cardiac failure and all, then we can give digoxin, will be a better choice. Then here that also we have only oral preparation available. And then next one is we have to give the anti-thyroid medications. So we have to manage the root cause. So anti-thyroid drugs, we have the propylthiouracil, methimazole and carbimazole.
Correct.
So propylthiouracil, all of these have similar effects, propylthiouracil and carbimazole. And that mostly in pregnancy, we have to prefer propylthiouracil more than carbimazole and methimazole.
Normal patients we give
methimazole or carbimazole. Propylthiouracil dosage usually in thyroid storm, we have to give a loading dose of 600 mg. And after that, you have to give 200 to 300 mg TID, 6 hourly we can give. And then carbimazole, methimazole also same, we can start at 10 to 20 mg. OD dosing, we have to taper on. We can start on around 6 hourly we can start, then taper down TID and BD and OD we can taper down.
Okay, so you will start beta blocker, you will start anti-thyroid medications. What else?
Then we can give iodides also, like iodides, these propylthiouracil and methimazole, carbimazole have common activity of preventing the synthesis of thyroid hormones, and propylthiouracil has added advantage of preventing the peripheral conversion of T4 to T3. So that is a more ideal option, because that will also help in the thyroid storm.
Correct.
And then
what other drug will help in preventing conversion of T4 to T3?
Steroids also we can start.
Yes. What is the commonest steroid that we can use?
Hydrocort we can give 50 mg.
Dexamethasone. Both of them will prevent conversion of T4 to T3.
So 50 mg 6 hourly we can start. And iodides also prevents the release of the thyroid hormones from the gland. So like we can give iodide sodium or sodium iodide or Lugol solutions can be given.
Okay.
And Then we have other like enterohepatic recycling can be inhibited by giving cholestyramines. That also will prevent the enterohepatic recycling.
Okay.
Then we should avoid giving any NSAIDs like aspirin should be avoided because it can displace the T4 from the thyroid binding globulin and cause aggravation of the condition.
Okay. So what did we start any of this for
Yes,
this
we
patient?
had started the patient propranolol 40 mg sustained release preparation BD because the patient was not on thyroid storm. Yeah, just because mild tachycardia was present. Patient had tremors and sweating, palpitation episodes. So we had just started on propranolol. And neomercazole dose we had increased from 10 mg BD to 20 mg TID. It was increased because the levels are not controlled, and we have to monitor the levels every 4 weeks. So after 4 weeks, you have to again repeat, and we should keep the T4 levels at the upper limit of the normal. So even that we have to do, and we did for that patient. And then for this thing, hypercalcemia, we had given IV fluids initially, hydrated at around 200 ml per hour, and we are getting output around 100 ml per hour, and we are giving intermittent Lasix. Furosemide doses were also given, and but the calcium was not improving, and we had started the patient on bisphosphonate was given. So first initially we have to, the issue with bisphosphonate is it will cause temperature spikes. So before giving bisphosphonate, we have to give a injection PCM dose. Then followed by that, we have to start on bisphosphonate. Bisphosphonate we dilute. It's a 4 mg. We'll take and we'll dilute in 100 ml NS, and we'll give it over 15 minutes. And if the patient has renal failure, then we can't give bisphosphonate. We have to look for other options like denosumab and all is available. So we give it over 15 minutes. If it is a mild renal failure and all, we can give it over as a slower infusion. We can give, and calcitonin, we have not. Calcitonin is also another way of managing. We can give calcitonin as a IM or subcutaneous. So calcitonin, we give dose around 4 to 8 units per kg as a 6-hourly dosing, and we can give it maximum up to 48 hours because it has tachyphylaxis, and there will be receptor downregulation. So by 48 hours, we'll have to taper and stop. And also the cost is on my higher side for both, so even for zoledronic acid and calcitonin as well. And then steroids also we can give in certain cases, like in patients, steroids may in zoledronic acid, main action is inhibition of osteoclast activity, so inhibits bone resorption. In calcitonin, it inhibits the osteoclast activity, inhibits bone resorption as well as increases urinary calcium excretion. Whereas steroids, what they do is they increase urinary calcium excretion but also decreases vitamin D levels. So any vitamin D related conditions like vitamin D excess conditions, we can give steroids. So you can give it in hypercalcemia of malignancy like multiple myeloma or other carcinomas which causes or any granulomatous conditions which causes calcitriol excess production. So that vitamin D production will be decreased. And also in vitamin D toxicity also we can give steroids. So that also around hydrocot 100 to 300 mg per day we can start on, or prednisolone orally we can start 1 to 2 mg per kg per day for 3 to 7 days we can give. That is the main role of steroids. And then denosumab only if in renal failure. If zoledronic acid is contraindicated, we can give denosumab.